We have the first speaker for this segment, Dr. Sangeetha Menon, presenting on the topic The Elephant in the Room Managing LGA Babies. She is an additional professor, Department of OBGYN, Government Medical College, Trivandrum. She is the assessor for the confidential inquiry into maternal deaths and the captain for maternal near miss surveillance and response, and a trainer in ORRT. Welcome aboard, ma'am.
Thank you very much. As usual, every time when I come for advances, I'm in a different college. So now I'm actually in Alleppey, but that's fine. Um, I must congratulate Dr. Jayakrishnan and his team, not just for batting it out for 25 years, but for delivering academics at par excellence. My heartiest of all congratulations. I've been given a very interesting topic, which is managing the LGA baby. Respected chairpersons and delegates. In the next 20 minutes, we'll just go through quickly what LGA is and how you really look at these babies. So each person has a different connotation where LGA is concerned. By and large, we take 90th centile. So when we plot it on the graph, any baby that is more than the 90th centile for us is LGA where gestational age is concerned. But the Royal College tells you 4.5 kg, the NICE tells you 95th centile, ACOG 90th, Wales takes 97%. And if you were to plot, as Jason Gardosi and his group do, with the symphysis fundal height, it is more than the 97th. But what we need to understand is, why is the baby large? So, are we dealing with an uncontrolled diabetes? Is it maternal obesity or an increased weight gain in pregnancy? Or is it just constitutional? Because again, the connotation for how you're going to look after these mothers and when you're going to terminate them is different. This is an old slide, but I like to repeat it again and again, which is the gestational related optimal weight from Birmingham. And here, obviously, as you'll see, these two women, one is tall, well built, the other, like most Asians, would be a smaller, their build is smaller. So, does it mean that if the big mother or the tall mother has a 4.5 kg baby, is that baby large? Or if the small mother has a 2.5 kg baby, is that baby small? If you go by our textbook descriptions and by our growth charts, this would be true, but it is not. So that's where you start looking at customized growth charts. Like, for example, I'm not expected to have a baby which would be the same size as Sheila Mani Madam's baby, though we've all finished our obstetric careers. So baby size should go by what is my height, what is my weight, what is my ethnicity, and what is my parity. And this is exactly what the customized growth chart is. And I would like to tell you that we listened to Gardosi in Hyderabad last year, and he came with his team. He actually taught us the chart, and it is available at a very minimal price. He will compute your data into a customer. So suppose you have a woman with these kind of parameters, he gives you the software to customize the growth chart for her and to use it. But again, when I say growth chart, it is not an ultrasound growth chart. We always think that the customized growth chart is an ultrasound growth chart. No, it is for people working in the periphery and in medical colleges everywhere to measure a perfect symphysis fundal height and plot it on. So, So if you look at this, you have the mother's details, her parity, weight, BMI, height, where she is from, and at the end of it, you get a term optimal weight. So right in the beginning, I know that this baby should be about 3.4 kgs. Then the growth charts are plotted. There's one that runs, in this case, I think on the 50th centile, the 5th and the 95th, but you can even change it. And there you'll find, as you plot the symphysis fundal height, it starts only at 24, 25 weeks. So at 25 weeks, if the symphysis fundal height is 25 centimeters, you can extrapolate what the weight is. So this is extremely useful for us to figure out what the growth drive of that particular baby is, which may not be the same for every individual. So, how do we really go about looking at fetal size? We palpate or we do a symphysis funnel height. We don't use the customized growth chart. And this is largely, there is a lot of ambiguity in this because of maternal obesity, because it could be a transverse lie, it really doesn't make any difference then. Or it could be large, small polyhydramnios, so it really may not correspond. Looking at weight gain really is no longer applicable today as a measure for either how much the baby is growing or how well the baby is going. And the thing that we rely on most, what our students and us call growth scans. Every time we are talking about growth scans, we're all worried whether we'd miss a late onset FGR. And that ultrasound would look at both abdominal circumference and estimated fetal weight. So, how good is ultrasound? Is it good? Really, not so. Only 40% of the time you may be absolutely correct, and the margin of error keeps increasing to 10 and maybe even 20% when the babies are very small or very large. So, your ultrasound prediction of size, especially if you're dealing with a large for gestational age baby, is not going to be good at all if you use ultrasound. So growth is something that is a serial measurement. I can't look at one scan and say this baby's growth is normal. That will tell me the growth at that point in time. It doesn't tell me what is the growth drive of the baby. But if I was to serially assess it, I know on what track the baby is going. Is it on the 50th centile track? Is it on the 80th centile? Is it on the 30th centile? And I also know if it's going to jump centiles. So, on a basic minimum, the abdominal circumference, if you look at the growth velocity of babies, it's actually quite interesting to think that the babies really grow exponentially at till about 20 weeks. It continues to grow, not that it does that it stops. Then there's another exponential growth at about 28 to 34 28 to 34 weeks, and then it doesn't plateau but it continues at a slower pace. But on an average, the abdominal circumference will increase by about 11 to 12 millimeters per week, or about 200 grams per week, if it is growing normally and there are no other medical disorders. Sometimes when you take the original, you take the abdominal circumference with the spine, the stomach, and the portal vein, the thickness of the fat of the abdominal circumference can be measured. That's where you take your outer to outer measurement. That thickness of the fat is really called the FAS, that is the fetal abdominal skin thickness. If it is more than or equal to 6 millimeters and above, it may be a factor that will tell you that the baby is big. And you can't just keep on doing growth scans because the baby also, you need to give it time to grow. So the minimum time between two growth scans should be 3 weeks for you to gain some knowledge about it. So let's say we do have a big baby. What are our worries? Will she have a sudden IUD? That's our biggest worry. If she's kept for a vaginal delivery, will she have shoulder dystocia? So should I do an elective cesarean instead? Should I induce labor at 38 or 39 weeks thinking that, at least 200, 400 grams I will save and baby may not be that big? What are the baby problems at birth? These big babies don't fare well at birth. And are there any long-term consequences to the mother? I must tell you right at the beginning that whether the mother has diabetes or not, just because she delivers a big baby puts her at risk. So the $1,000,000 question there is she a diabetic? That's the first thing you have to do. And if your baby is growing above the 90th centile, look at her sugars if you haven't looked at it recently. But if she's not a diabetic, a large for gestational age baby per se, just because the baby is large, is not a high risk factor for fetal hypoxia. So the baby is not going to die in utero because of fetal hypoxia if there is no diabetes. Even otherwise, if she had diabetes, it doesn't die because of fetal hypoxia. It dies because of ketosis. It dies because of a metabolic problem. So in these big babies, you may not even need continuous CTG monitoring, because an intelligent auscultation would do just as well, especially if you have a resource poor labor room. So these babies are not problematic in utero, at least up to 39 weeks. Now, I must let you know that there is HAPO, we all know, the hyperglycemia and adverse pregnancy outcome. But there is a follow up study to the HAPO, and there is a follow up study to the MIG as well, which is the metformin in gestation, which is called the MIG TOFU trial. Now, when they looked at HAPO, what was the original HAPO? Even small excursions of sugars, that is, you expected it to be 120, it became 139, or it became 142. Even small excursions of the sugar above the mean could relate to poor outcomes. So at 30 weeks, if you had small excursions and then you put her on a diet and got her to have her sugars in control, good. But at the same time, the risk for an adverse outcome still persists if the baby has been exposed to hyperglycemia. That was the synopsis or the sum total of the HAPO. What did the HAPO follow up studies say? They looked at quite a large number of babies, which makes us really believe this study, which is 4,000 odd babies. And they followed them up for about 10 to 14 years who were born to diabetic mothers. They also had a group whose diabetes was not there. The researchers were totally blinded to which baby they were looking at. And they found 10.6, which is a very significant section of those babies who were born to diabetic mothers had impaired glucose tolerance, compared to 5% who did not have any form of GDM. So those babies are at risk. And type 2 diabetes at 14 years was far too low to actually have any significance. But at the end of it, we must understand that offspring who are exposed to untreated or poorly treated diabetes in utero are insulin resistant at birth or 10 to 14 years later, and they will have a limited beta cell compensation. That is, they can't be exposed to that much of hyperglycemia. The pancreas will not live up to the time and it will not put up that much more insulin. So their beta cells are limited at birth itself. So even the large for gestational age baby whose mother never had diabetes, they also have a risk of developing diabetes later on because they are large. And there is actually U-shaped, this just makes us think. I think Uma had said in the morning about, she's not talking about screening because nobody knows which is the best method. This actually makes you think, because there's a U-shaped association of maternal fasting glucose and large for gestation. That is, if your fasting sugars are high, C-cod, C-peptide levels, which are all insulin breakdown products, will be high. Your macrosomia is high. Your cesarean section rates are high. So the association of postprandial hyperglycemia is not really that significant. It is significant, but where the LGA baby is concerned, it may not be so. So there you should think, am I really okay in using a screening tool that doesn't have fasting sugar in it? Sometimes I worry that if there is no fasting, will there be a subset of women who will have only postprandial, will not have fasting hyperglycemia and only have postprandial hyperglycemia? So this is something you need to think of. And LGA also has a 2 to 3 fold risk of an IUD, but when associated with GDM, not otherwise. Later in life, as I said, they're likely to develop obesity, metabolic syndrome, and diabetes. And this U-shaped distribution exists. This is not very sure, but even hypoglycemia, they say the mothers who have less sugar, the babies are drawing in more of that sugar and they are growing big. So the U-shaped association exists with both hyper as well as hypoglycemia in the mother. Here comes the elephant. I wonder why I was chosen. I'm just thinking, but I'm just stepping in for somebody who is unfortunately not here. Lakshmi Amal could not attend, and so I'm just doing a step in for her. But definitely the baby, the elephant in the room phenomenon is definitely there. That I'm not going into the details of shoulder dystocia in large detail, but just for you to understand that when you have a shoulder dystocia, do not pull from below. Do not push from above. You must be conversant in the steps of the drill. Your hand must go in to the accessible shoulder. If both the shoulders are not accessible, then heaven help you, go back and do a cesarean section and push everything in and deliver. But if and most likely the posterior shoulder will be accessible, use that posterior shoulder and go ahead with your maneuvers, but don't pull from below and don't push from above. So let's look at shoulder dystocia in these big babies. Overall, if you look at it, the shoulder dystocia prevalence is just about less than 1%, 1.25 and 0.2, 0.8. So not very large. But when you look, when the babies grow to 4 to 4.25, it's about 5%, increasing to almost 21% when the baby is 4.75 to 5 kgs, which is really not acceptable. Even at 4 to 4.25, the 5% worries you. So cesarean section is recommended when the fetal size is more than 5 kg without diabetes and more than 4.5 kg with diabetes. Again, the thing you need to consider is your ultrasound prediction correct? And you're talking about birth injuries in these babies, but remember clavicular fractures, and we have all seen them, can occur in women without shoulder dystocia as well. So, this is the kind of thing that worries us. A big baby, the head is out, hardly undergoing restitution, becoming blue and suffused. You just can't put in your hand anywhere and you worry and you suffer. It's a nightmare. But how do you mitigate this? Do you really go and do cesarean? Definitely not. So, whether you induction of labor in these kind of babies, that is, you will follow the induction guidelines for diabetes with or without the suspicion of shoulder dystocia, and you'll go ahead with the cesarean section if the baby is more than 4.5. But let's say the mother doesn't have diabetes, then the shoulder dystocia rates for these kind, whether you induce them or not, were not very certain, but definitely a little lower at 7%, whereas 21% if you did not induce. But again, remember, induction could mean a whole lot of problems by itself. And when you induce, there is definitely, when you bring these babies out, an increased incidence of having a significant tear, which is type 2 and greater, which is about 29% versus 6 if you didn't induce. But remember, there is absolutely no difference in perinatal death, brachial plexus injuries, or any of the other your clavicular fractures. None of the birth injuries decrease if you induce. So think about your induction protocol very sincerely. So when I'm delivering the large baby, what safety nets do I have to have? Think very, you mark that in your, actually we had a case in Alapura last, not in our hospital but in the district. There was a panel 2 years ago, the baby delivered, the baby has a permanent herbs, and now they're suing the obstetrician. I think the most the baby was only 3.5 kg, but when the baby was looked at on ultrasound at 34 weeks, it was already 3.3, and it was that was greater than the 90th centile. So if you find a baby that is bigger in your growth scans, mark it off as a high risk factor, note it, because you must be prepared to tackle these kind of babies. And if in these kind of babies, if you have first, if I was delivering a 2.8 kg baby and the cervix was dilating slowly, I'd probably wait. But if the cervix dilates slowly with the 4.5 kg baby, I will go and do a cesarean section. Think of protracted descent in the second stage, that could be a problem. If you use an instrument in these kind of babies, it has to be used only in the theatre, not in the labor room. Preferable to have these women on an epidural, at least in our kind of situations. Await restitution, do not pull on the shoulders or on the head before restitution has occurred. I'm happy to say that we have, as the UK has, which is the prompt protocol, practical obstetric multi-professional training, we have it as well. We have both the EMOCALs, which is now metamorphosed into PPMD, where the same shoulder dystocia is taught. And in the neonatal period, these babies have problems. They have hypoglycemia, they have birth trauma, they have respiratory distress, they find it a little bit more difficult to breathe, and there is an increased incidence of NICU admissions. Later on, they are asking for diabetes as well as obesity. what happens to the mother? See, everything is a public health opportunity for you to think. If this mother delivered a 4 kg or a 4.5 kg baby, she must be followed up regularly with sugars, told lifestyle modification, look at sugars every year, because they themselves can develop diabetes or pre-diabetes to the tune of almost 20% if they have delivered a large baby. And it's only about 15% if she, this is the non-diabetic mothers who have delivered a SGA baby. So use this large baby as a public health intervention for you to actually look at these mothers in the long run. Thank you very much.